So there are so first of all, where is recording thing?
It's recording.
Recording. Yeah, it's recording.
Yeah.
So share my screen. That's not showing.
It's not. Close it or reopen.
Yes, there you go. Okay, good morning, good afternoon, guys. And I hope things are fine and you must have enjoyed your midterm exam and I cannot see your smiling faces, but I'm sure you must be in good health and everything is fine. And I have seen your appeals and everything. And probably you spend time in looking into the session where we are talking about thoracic wall. We have started with the beginning of this block, and I have talked about certain concepts in the beginning, and then I have revisited those in different locations when we were talking in different sessions. So today I'll be starting with the main thing. We have settled down for so many things. So we stopped our previous talk at one place, and that was when we have reached close to the, we are doing the thoracic wall and we were talking about the diaphragm. So now, just this is a quick recap of what we were learning before. So just this will help us to understand so many things. So just you're looking at what? You're looking at the construction of thoracic wall, and you can see that there is a diaphragm which has been shown, and these are the margins of the lateral margins of my thoracic wall. And look at it, this has been cut so you can see inside. So let's put things inside, and this is my right side, this is my left side. Guys, this is very important. When you're looking into any image, any x-ray, anything, you should be very clear about the orientation. That's why it's really important to understand even for the x-ray. So now let's start the ball rolling. So what are these? This is the rib cage which has been cut, and we know about it. The partition which separates my two cavities, the thoracic cavity from the abdominal cavity. Let me place it on a side so it should not be obstructing the view. So you're looking at what? I'm sure everybody knows this is my diaphragm. Are we good with that? So this is the diaphragm. Going further, what are these? These are the lungs and pleura. We haven't talked about it, but we'll be talking about day after about lungs and pleura. There will be a full lecture where I'll be talking in detail about lungs and pleura. And now you're looking at the parietal pleura, and it has been opened anteriorly so we can see inside. And now let's put the lungs here. This different color, this purple color is representing what? My lungs. And then you have seen the right and left lungs, and they are covered with which pleura? Visceral pleura. And then we all know there's a parietal pleura. We'll be talking about these shortly. So let's label it. We talk about that before, even the apical parietal pleura, we call it capula. There are so many names for that. I have mentioned in my previous talk. So for that, you need to reconnect and you have to listen to my previous lecture. And then this is what you're looking at, the pleura which is related to my rib cage. We call it costal pleura, because the word costa we talk about is the combination of rib and vertebrae together. That makes the costa. And this is one which is facing my mediastinum, so I'll be calling it mediastinal pleura. So both of them are, so the parietal pleura, the part of the parietal pleura which is in close relation with my body wall, the thoracic body wall, we call it costal pleura because it was related to the ribs and the in between intercostal muscles. And now the part of the pleura which is facing towards the mediastinum, that we give it a name as the mediastinal pleura. But all of them are, we are talking about the parietal pleura. The visceral is adhering with the lung. Now, which is going to the diaphragm, the name says itself, it must be called diaphragmatic pleura. So the parietal pleura, the part of it which is facing to the apex, we call it apical. The part which facing the rib cage, we call it the costal pleura, and the part of it which goes to the mediastinum, we call it mediastinal pleura, and part of it which goes to the diaphragm, which is facing the diaphragm, we call it diaphragmatic pleura. Are we good with that? Perfect. So now, what are these? Can you see these angles? These angles, these are the angles, and these are called costo diaphragmatic, because it's between my costa. I'm sure everybody knows what is costa. Costa is a rib and a vertebrae together. So between costa and a diaphragm, costo diaphragmatic, and it's a space, a potential space. We call it costo diaphragmatic recess. And what happens if we have any fluid which is accumulated into my pleural space, and if person is standing, by gravity all this fluid will be present in these recesses, which are called costodiaphragmatic recesses, and this space will be filled up with that fluid. So a simple amount of fluid can become visible within these. If I'm hunting for some fluid, I can just target these costodiaphragmatic recesses, and if my angles, which are acute now, if they become obtuse, it means I have presence of some fluid, and then I need to look into if the patient is been presenting with some of the complaints which are related to some problem with the breathing pattern. So now this part, the fibrous pericardium, we all know heart lives here, and this is the fibrous pericardium which is adherent with the diaphragm. It is non-separable. Now what I'm showing you, these are the certain parts which which we haven't learned them yet. So this is a fissure. This is something which is going obliquely from my rib cage towards my diaphragm. So it's in the substance of the lung. So we have a name for that. So this is a fissure. We'll talk about that. Just ignore it at the moment. So this is how my lung is being divided into different lobes. So it becomes a superior lobe and an inferior lobe due to this partition. And then on the right side, what we can see the same oblique fissure, and then there are two fissures there. So on the left side, we had only one fissure. So that gives me two, one and two, superior and inferior. And there I have two fissures. So one is going oblique, one is going horizontal or transverse. So now I'll having on the right side, I'll have three major lobes, and these are superior, middle, and inferior. So that's the difference between my right and left lung. So what starts appearing? Now the venous system, look at it. Two internal jugular veins, the right internal jugular vein joined with the right subclavian vein. Left internal jugular vein joined with the left subclavian vein makes what? Right brachiocephalic and left brachiocephalic. Look, right brachiocephalic is straight as compared to what? Left. It is more oblique and it is going diagonally. It's crossing all the way and it's been connecting. Both of them, they join and they give us superior vena cava. Let's label them quickly. Brachiocephalics, internal jugular veins, and we are getting superior vena cava. Are we good? Perfect. So we learned next was the aorta. You're looking at the arch of aorta, which becomes descending aorta. Ascending, arch, descending, we also call it thoracic aorta. The moment it passes through the diaphragm, we call it abdominal aorta. When it reaches to the fourth lumbar vertebrae, then it becomes common iliacs. So this is my arch of aorta and this is my thoracic aorta. Are we good? Now look at it. From my arch, on the right side, I have one major artery. And on the left side, I have two. So what is happening here? This right one is my brachiocephalic trunk, and these are my subclavian artery and vein, and these are my common carotid arteries, which becomes external and internal carotid, and their job is to control my head and neck region. They are supplying there. So now, what is this? This is my pulmonary trunk. When all the body blood from above through superior vena cava and all below from inferior vena cava reaches to right atrium of my heart, then it being pushed into the right ventricle, and from the right ventricle it has been pushed for pulmonary type of circulation. It has to go to the lungs. So this is the structure which takes the blood which has been collected in my right ventricle. When the right ventricle compresses, this blood is being pushed on the right and left side through a common structure which we call it as the pulmonary trunk. Excellent. And takes the blood to my right and left lungs. For what? For gaseous exchange. Very good. So now what are we looking at? Now something else has been added up, and you're looking at a gland. We haven't talked about it. This is my thyroid gland, which is present in my neck region. And then you're looking at, closely associated with that is trachea. You can see it's coming all the way at T4th level, which you cannot see at this moment, but you can see it's been bifurcating into right and left main principal bronchi, right for right lung, left for left lung, and then they divide and redivide and redivide. We will be talking in our next lecture in detail about this. And then this is the thyroid gland, and it's been followed by, now look at it, from the lungs, the blood has been returning, which is rich in oxygen. So this is going where? Its destiny is to reach my left atrium. Excellent. So these are my pulmonary veins, which are bringing blood to my, and look at it. This is my, now in the picture, you're looking at the inferior vena cava. And then what is happening next? This is my esophagus. See how closely structures are present and related within my posterior mediastinum. And then this is the esophagus, and this is the thoracic duct, which commences through this opening. We'll be talking about it shortly, and then it's going to the left side of the body to drain, or look at it. It's going, it was on the right side. It started its journey from the cisterna chyli. It pierces the diaphragm, it passes through the diaphragm, it runs on the right side, but then it deviates its journey towards the left side, and ultimately it hooks around. Either it opens the junction between left internal jugular vein and left subclavian vein. It may open into the brachiocephalic, so it's his choice. But mostly, this is the commonest presentation of my thoracic duct. We talk about that. So now this is where it opens, so the drainage. Now what are you looking at? The new thing which I have added, can you see that? This blue thing. What do you think is this? Any idea? Keep thinking. This is my azygous vein, and you're looking at, these are my different posterior intercostal vein, which are named according to the space where they are running. After that, you're looking at posterior intercostal arteries. We all know from where they have been branching off. They are from the thoracic aorta, posterior intercostal arteries. And now what has been coming up? You can see that this is my vagus nerve. We are on the left side. Vagus nerve comes down, goes, when it crosses anteriorly in front of the arch of aorta. It gives so many branches on its way. When it leaves the skull base, it gives so many branches. But we are not talking about its branches in detail, and the branches which are just associated here. So one of the branch which is going under the arch of aorta, that has been labeled as left recurrent laryngeal nerve. And the right recurrent laryngeal nerve, it will be different. Why they are different, Paul must have explained to you in his developmental lecture when he was talking about the fate of this different, the arterial system, when he was talking about the branchial arches, and there he must have explained why on the right side it's going under subclavian, and what happens on the left side it's going under arch of aorta. If you are still in doubt, just connect to his presentation. I'm sure he must have explained, and I'm sure most of you have seen this azygous vein and these recurrent laryngeal on cadaver. So look at it. After being hooked around, it's going back because it forgot. So it's going backwards. It runs next to my trachea because recurrent laryngeal nerve, I'm sure you all be knowing, it's one of its primary supply is what? It is controlling my vocal folds. In the larynx, the blood supply of the larynx is being controlled in a big way by this recurrent laryngeal nerve. This is my left vagus and left recurrent laryngeal nerve. And this green structure, we all know about it. This is my ligamentum arteriosum. And when it was patent, it was called patent ductus arteriosus. And look at it. The right vagus, it's coming down. And this is the right vagus which has been shown you. I'm not talking about it where the right recurrent laryngeal nerve has been given. It has been given. You can see that it's been shown behind, but that's not possible to show you everything in this image. Look at it. My right vagus and left vagus, when they reach to the esophagus, they make an esophageal plexus. And when this rotation occurs, this right becomes and left becomes, they become anterior and posterior trunks. We have talked about it previously. So this is the esophageal plexus, which has been formed by what? The parasympathetic contribution is coming from my vagus nerves. Collectively, we call them vagi. And look at it. These structures which are entering the hilum of my lung, and this has been given a name, root of the lung. So you can see that pulmonary veins has been shown up in the root of the lung. There's the inferior vena cava. We talked about it previously. Now look at it. What are these two structures? Which are going in front of the hilum. Guys, this is the point of differentiation. The nerve which goes behind the hilum of the lung and the nerve which goes in front of the hilum of the lung. The one which goes in front of the hilum of the lung and seen going all the way down to the diaphragm. No matter we keep a heart here or we don't keep a heart here. But if you see that, it's going in front of the hilum and going to the diaphragm. It's not disappearing inwards. This structure deserves to be called as what? Phrenic nerve. You can see that it supplies the diaphragm. It supplies, I'll be talking a lot about phrenic nerve today. Don't worry for that. So these are my right and left phrenic nerves. So now, internal thoracic artery, and we talk about them. I need not to go in those details and look at it. It's been accompanied by a venous system. So these are the internal thoracic artery and veins. And then we are looking at pericardiophrenik. We talk about that, internal thoracic branches. These are my phrenic nerve and pericardiophrenik vessels. You all know at what level internal thoracic divides into its two branches. So guys, let me read it for you. The vagus nerve passed through the mediastinum behind the root of the lungs, whereas phrenic nerve pass in front of the root of the lung on their way to the diaphragm. So guys, this is the diagnostic point. This is the zibda whole of this slide, that if you are given in your exam situation, differentiate between vagus and phrenic. So the main point is the hilum of the lung. In the posterior mediastinum, in front of who go behind the root and who goes in front of the root. Look, it's not necessary you should place a heart here. You may not place a heart here, because if I put a heart here, so many things will not be visible to me. But this hilum, root of the lung, is the main structure. If things are going behind, we call it vagus, and if it is going in front, we call it phrenic. But we are not only relying on this structure. Phrenic, we can see it ourselves. It's going all the way down to the diaphragm. Okay, guys. So now what we were talking so far, it's been shown up in this image. I need not to explain further. You can see that, you can identify. Vagus has not been shown here, but you're looking at very carefully. The phrenic nerve has been shown all the way down. You're looking at internal thoracic artery and its different branching pattern. So phrenic nerve, primarily it's coming from C3, C4, C5. What are these C3, C4, C5? These are my spinal nerves. And from there, their ventral rami, they join like my brachial plexus, like my lumbar plexus, like my sacral plexus. So they join and then they make one nerve. And that nerve is called phrenic nerve. Now question is, phrenic nerve is given at C3, 4 and 5. So why it has to go all the way down to reach my diaphragm? So primarily what happens, when you'll be explained in the developmental lecture about the diaphragm, Paul will be talking about that. The structures with the sources which are responsible for the development of the diaphragm, we need four things. And now one of the contributing factor for the making of diaphragm is the septum transversum, and that develops in the neck. And when it migrates down, it drags its nerve supply along with that. And the fibrous pericardium also coming from that source. Mediastinal pleura also coming from that source. More detail will be provided by Paul. That's why this phrenic nerve, it has to travel from the neck and it has go all the way down to the level of the diaphragm, because diaphragm migrates. Originally this develops in the neck, then it descends down, and due to its descent, it drags its nerve supply. That's why when there is any problem occurring at this level, we feel the pain. Even the lower part, if you see the lower part, it also supplies the diaphragm. So once there is an inflammation of the gallbladder, the pain of the gallbladder also radiates to the tip of the shoulder, and that explains the pathway of the pain taken by this phrenic nerve is responsible. So if there is, and it is basically a sensory nerve, and it is motor only for diaphragm. If we irritate the pericardium, the pain sensation, a sharp pain can be elicited. So in the mediastinal pleura. So these things are responsible and they are innervated by my phrenic nerve. You can see in that. And then it's a motor supply for my diaphragm. Are we good? So guys, this phrenic nerve, you are expected to be very good with the phrenic nerve. Now we are looking at what? We are looking at the aorta. We talk about it. You can see the posterior intercostal arteries. But why I'm bringing it here? You can see that this aorta, the moment it passes through an opening in the diaphragm, we call it now abdominal aorta. And you can see it's branching here. But that's not my talk today. You can see that there are certain structures which has been made here in this. Look at it. Arches. There is an arch here. In the middle, I call it median. I call it medial and I call it lateral. So just these are my posterior attachments of the diaphragm. So now we'll be learning about them in detail. So now we are looking at the diaphragm. We are looking from below. It's an inferior view. And there you can look at that, the central tendon of the diaphragm, which looks like a club. When we play cards, we have the club. Those who play card, they know what is the club thing. So now you can see there are, this is a vertebrae. This is the vertebral body. This is the spine, the pedicle, and the laminae. And look at it. These are the muscles. We'll be talking about them shortly. And this is anterior. This is sternum. Guys, can you see this arrow, this arrow, this arrow? Pay attention to them. And now we are going for the attachments of the diaphragm. There is one. So I'll start labeling this image. So this is the xiphoid process. This is my costal margin. This is my first lumbar vertebrae, L1, L2, and L3. Now what happens? This is my psoas major muscle. And who's next to it? Think. We talk about that. Quadratus lumborum. We talk about quadratus femoris. And now this is my quadratus lumborum because it's close to the lumbar vertebrae. And why quadratus? It has 4 angles. So now let's take the attachments. Guys, now look at these arrows very carefully. These arrows will move. Look at it. This arrow has moved from here to here. So what I'm trying to show you, the anterior attachments of what? Of my diaphragm. So sternal origin. And then I'm going to what? I'm coming to this arrow. That's the costal origin. And then, so my diaphragm is coming from the sternum, is coming from the costas. We all know what is a costa, and then it is gone out of the image. And these are the lumbar origins. So for the lumbar origins, look at it. This is, I told you, this is more lateral arc. So I call it lateral arcuate ligament. This is my, if this is lateral, it will be medial. Your foundation block concept. Medial arcuate ligament, because they are like an arc. What are these? These are the condensation of the fascia who covers my psoas major and quadratus lumborum muscle. They become thick. And this thickening pattern is given these names. So we have lateral arcuate ligament. This thickening is called medial arcuate ligament. So now what do you think this thickening should be called? This will be median arcuate ligament. So now there's a triangle here. And now these are the 2 crusts. Together we call them cruras. You can see on the right side and on the left side, they are differently attached to my lumbar vertebrae. So right and left cruras making up the median. So these 2 condensation, they are making up my median arcuate ligament. And that's my median arcuate ligament. So diaphragm is attached in front to the sternum, to the costal margin of lower ribs, and then posteriorly it's coming from where? From my median arcuate ligament, from my medial arcuate ligament, and from my lateral arcuate ligament. Are we good? So now what is that? This is the muscular part, and this is the fibrous part of my diaphragm. Are we good with that? This is the central tendon. And this is who's the structure? Think. Any idea? This is the aortic hiatus. T12, L1. Guys, don't forget these levels. We love to ask them. Aorta passes from this level, T12, L1. Between T12 and L1. And this is what? Guess. This is my esophagus, T10. Be very specific. And this is my inferior vena cava. Now, aorta passes through the muscular part of the diaphragm. Esophagus passes through the muscular part of the diaphragm. But inferior vena cava, which is at T8 level, it passes through this fibrous part of my diaphragm. What happens? What is the difference? Why is that? Guys, aorta is a very strong organ. It can expand. So if it's in the muscle, even if my diaphragm is contracting, it will not be affecting my aorta. Esophagus, when there's a food, there's a propulsive movement, so it can pass out. No matter diaphragm is in spasm or not, but it can find its way. But my inferior vena cava is the main receiving channel of my lower body. So it has to collect blood from my lower body part. So all the way it has to stay open. So it is being connected to this fibrous part of my diaphragm, the central tendon. So it keeps it open. No matter what, we sleep, we awake, we run, we swim, we dance, this opening remains open. So the net point, inferior vena cava, T8. Esophagus, T10. Aorta, T12. Remember this. For more detailing, you can add on, but simply T8, T10, T12, a difference of 2. There is my aorta. Look at its branches given under surface of the diaphragm. What do you think? What should we call them? Diaphragm, another word for diaphragm is phrenic. So anything with the name of phrenic, guess. So these are my right and left inferior phrenic arteries. Look at it, my esophagus. When it's coming out with the vagi. What are these? These are vagal trunks or vagal nerves that we need to look at it. So these are anterior and posterior vagal trunks. We all know because of the rotation this has happened. And there is my inferior vena cava. So these are the major structure who comes out of these openings. You need to be good at it. What are their levels? Vertebral levels. And what passes through them. Now look at it. This is what? We didn't talk about any opening here, but from the muscle, a nerve passes out. And who this nerve should be? Guys, this is nothing but my left phrenic nerve. So left phrenic nerve pierces my diaphragm and comes out and supplies on the undersurface and also supplies the parietal peritoneum. So this is my left phrenic nerve. And then look at it, my right phrenic nerve. The left passes through the muscular part and the right passes through the fibrous part, central tendon of the diaphragm. So these are my right and left phrenic nerves. And look at it. What are these in front? Guess. These are my anterior branches of left and right phrenic nerve. So phrenic, before it gives certain branches and they reach to the diaphragm, under surface of the diaphragm at different levels. And we name them. So you are looking at the anterior branches. So look, what has been coming out through this? What is this? Medial arcuate ligament. I can see the sympathetic chain. 2 beaded strings has been going close to my vertebral bodies. So these are the sympathetic chain. And together they are called sympathetic trunk, and they give splanchnic nerves. What are the splanchnic nerves? Visceral nerves. I remember there was a question on splanchnic thing in your midterm exam, if you remember that. Look at it, who this nerve should be. Guess who this should be. This is my greater splanchnic nerve. Do you remember when we talk about greater and lesser and least splanchnic nerve? Yes, the second lecture in CVP block. When I was talking about the sympathetic, I told you there are 5 options for sympathetics. And one of the option was they are given branches which are going to supply in the abdomen, the viscera in the abdomen, and they are given the name of splanchnic nerves. And they are divided in 3 categories. They are the greater, lesser, and least splanchnic nerve. So you're looking at greater splanchnic nerve is going to the celiac ganglion. It carries the sympathetics. And now this one, below to that, this was greater. What do you think this should be? You can put yourself the name. This is lesser splanchnic nerve. So we are left with the least. So where is the least? This is the least splanchnic nerve. So yes, guys, don't think they are only present on the right side. We also have them on left side. So greater, lesser, and least splanchnic nerves, they are the sympathetic contributions. Are we good? Now, this is what we have talked about. You're looking at a diaphragm from above and you're looking at a diaphragm from below. So you try to understand the different pattern of supply. Obviously, on the superior surface, we have superior phrenic, and the under surface, we have inferior phrenic. Are we good with that? Now, we talk about the rib cage, and we have talked about the distribution. We talk about the muscles. We have talked about the ligaments. So now let's start talking about different joints. A joint between the manubrium and the body, we call it manubrosternal joint. Are we good? And then the joint between my first rib and the manubrium. First, sternocostal joint. So what is this an example of? This is an example of synarthrosis. Manubrosternal joint is an example of fibrous joint or symphysis. So there is a small range of movement. If you remember, in foundation block, we talk about these classifications. So synarthrosis applies a joint that is immovable or almost, so there is a minimal movement we expect at this level. Guys, these movements are important for our today's understanding, which are coming up. Now you see there are further joints between these ribs and the sternum, the lower ribs. These are sternocostal joints and these are synovial, except the first one. First one, like this formula is applicable even here, but for the simplicity, it's not been shown up here. So the first rib, the joint of the first rib through its costal cartilage with the sternum, that one is a synarthrosis. But the remaining ones are synovial. So articulating surface, they are covered by fibrocartilage, some gliding movements is occurring. And then what do we have here? This is a different pattern. The cartilages are joining with each other. These are interchondral joints and they are also synovial. And look at it. The joint between the costal cartilage and the rib. What is this? This is costochondral joint. This is fibrous. There is no movement. So guys, you need to understand where we have movement and where we don't have movement and what are the names of the joint. There is no need of any further detailing, but this is a must know information. So what type of joint is this and what type of movement is possible at this joint? Because this helped me to explain out my further understanding of our today's session. So now the costovertebral joints are also important in respiratory movements where the heads and the tubercle of the ribs articulate with the demifacets on the thoracic vertebral bodies and their transverse processes respectively. They have not been shown in this image. So we are talking about the joints which are important for our respiratory movement. So let's explore things step by step. So now we are looking at the rib cage from a side view. This is a lateral view of a rib cage. And now we are talking about the movements of the rib cage in respiration. When we are bringing some respiratory movements, how this rib cage behaves and how it's possible for expansion and then going back and then increasing different dimensions so that the lungs can be prepared to accommodate to suck in air. So now let's focus at the lowest point of the rib, upper ribs are their anterior ends. So this is their lower end. When they elevate, they move in pump handle fashion. I hope everybody knows what is a pump handle. If not, I will show you shortly in an image. So I draw a line at this level, this green line. And then I draw a vertical line. One is dotted, one is a complete line. So pump handle movement of the upper ribs increases what are they for? They increase my anterior posterior, like a distance from here to here. From anterior to posterior or posterior to anterior diameter of the rib cage is increased by pump handle. How this is helping? So who is contributing? From rib number 2 to rib number 6. So what the rib number 1 is doing? We all have talked about rib number 1 is not moving. So rib number 1 is providing me a base on which my whole rib cage, it moves up or moves down. So my rib cage going up or going down, the main fulcrum, the main base is provided by my first rib. If my first rib starts moving, then this is not possible. Are we good with that? So that we need to understand. So who are my upper ribs? Rib number 2 to rib number 6. So what is the catch here? Pump handle. We need to look at it. What is this pump handle? And the lowest point of the upper ribs are anterior ends. So we all know what are their lower ends. So now these are the lower ribs. We have used 2 to 6, so now we are left with 7 to 10. 11, 12, they are floating, so they cannot reach to the sternum, so they are not player in this game. And then their movement, they are giving me transverse dimension. They are increasing in transverse diameter, and the upper ribs, they are from anterior posterior, posterior anterior. So this width, transverse and anterior posterior. So their different ribs are contributing. So this is the red line. So then the bucket handle movement of the lower ribs increases the transverse diameter. How it is happening? Shortly I'll be showing to you. So now look at it. Upper ribs. What were upper ribs? Rib number 2 to rib number 6. Happening here. Just look at it. I'm showing you, just focus from rib number 2 to rib number 6. We all know this is sternum, this is the vertebral body, and these are the ribs. And you're looking at the upper ribs. We didn't talk about first rib, that is fixed. So now look at it. This is the normal position of my rib cage. Upper ribs. We talk about pump handle movements. Look at it. Can you see this dotted line? Can you see that? It has been lifted like pump handle. I lift it. So we have lifted this rib cage from this position to this position. When we lift it up, this distance from posterior to anterior or from anterior to posterior will be increased. Look at it. If I go back, it was here. And when I lift this whole structure, it comes forward. So what happens? My distance has been increased. The distance, this was my original distance, and now I have an added distance. So this caused the distance, the increase in a distance from anterior to posterior dimension. And this action is pump handle. Like this was a pump, everybody knows this. Even if you go to the old villages, mazras, you might find this type of thing. And if we have lifted this handle, this is the handle. When we lift it up here, so as a result we get water. But when we lift this rib cage, we have increase in anterior posterior dimension of my rib cage. And who are responsible? From rib number 2 to rib number 6. Are we clear so far? Guys, these are concepts and you are expected to be good. And you can see what happened, what changes are occurring within my rib cage. And who are responsible? Rib number 2 to rib number 6. So now, going further, so I get a net result, what I get, and increase my AP diameter. Anterior posterior dimension has been increased. So I have expanded my rib cage from anterior to posterior dimension, so I can provide a space for my lungs to expand when they are receiving air. And now let's look from the front. And now we are targeting the sideways. So rib number 7 to 10, we talk about bucket handle. So we are looking from a side view, and this is from front. So now look at it. In the second phase, what will happen? Second stage. So we are lifting it up. Like this is a bucket, its handle. When it's down, this space was less. And when we increase it, when we lift it, this dimension is increased. So what are we increasing? The net increase from here to here. You can see that this dotted line is falling out of this original lines. Look at it, original lines, and look at it, added lines. So I'm able to increase this dimension from side to side. Transverse dimension has been increased. So who's bringing it? Bucket handle movement. Which ribs are responsible? Rib number 7 to rib number 10. For pump handle, rib number 2 to rib number 6. These points need to be very, very clear. Going further, transverse dimension has been increased, so it is happening simultaneously. It's not like one action is done and then you're sleeping. No, they're all occurring together. And then, so we have increased the dimension anterior, posterior, sideways. Now we have to increase vertical as well, because we need to, basically what we need to do, we have to increase the space within our rib cage. So now for that, this is the original position of my diaphragm. So to increase that, so I have to bring it down. So as a result of that, so this space will be increased. So this blue was when I was exhaling air, when I was throwing air out. And when I'm preparing my rib cage to take air in, so I have to bring it down. So that will help me to increase this vertical diameter. So this vertical dimension has been increased. So to accommodate, before inspiration, I'll prepare my rib cage. I have to increase anterior posterior diameter, I have to increase transverse diameter, and I have to increase the vertical diameter. Are we good with that? Perfect. So vertical dimension has also been increased. So diaphragm descends and contracts the abdominal viscera. The motion of the central tendon becomes arrested and it becomes a fixed portion from which the fibers of the diaphragm continue to contract, thus causing the lower ribs to elevate. This causes increase in the transverse diameter of the lower rib cage, completing that created through elevation of the lower ribs by intercostal muscle. So all of them, they are playing their role And what we are getting an increase in anterior, posterior, transverse, and vertical dimension. This all is needed for inhalation of the air, for taking the gases in. So now this is the central tendon of the diaphragm, which I was just reading it for you. And now this is the central tendon, we talk about it, and this is what the increase in the transverse diameter, vertical diameter, we all achieve that. So now let's summarize all this. Rib number 2 to rib number 6, pump handle, causing what? Increase in AP diameter. Rib number 7 to rib number 10, causing what? Transverse diameter, increase in transverse diameter, and diaphragm, increase in vertical diameter. So we achieve all these in these three different levels. So once we have achieved that, now our lungs are ready to expand. We inhale air through our nostrils, and air goes in through the trachea, and then it divides and divides and divides and reach for to the bulla level for gaseous exchange. And once we are done with the gaseous exchange, so there's a recoil, and then everything goes back and everything goes to its normal shape, and we are breathing. If somebody watches us doing this movement, we can be seen breathing, inhaling and exhaling. Are we good? So let's see now the muscle who are responsible for that. Coming back to my rib cage. So there is my rib cage. We talk about it. So like you and me talking right now, this is quiet respiratory movements. We are not in exertional force. And if see you are climbing a mountain, you are your force, or you come after running, how you're breathing, you're doing like that. That's not quiet respiratory movements. You are audible, but normally see you are sitting in front of your device. If you're sitting, so you are inhaling and nobody can listen to you, you are breathing in or breathing out. But once you're running or you're climbing up, or maybe a dog is chasing you, then you are not having a quiet respiratory movements. So let's see who are the responsible things for my quiet respiratory movements. So I have intercostal muscles and diaphragm. So primarily they are responsible when I'm at comfort. We all know who's this. External intercostal, we talk about it. Internal intercostal, and then innermost layer is there. We talk about these structures. Now this is the diaphragm, we talk about that. So these are the muscles which are responsible for quiet respiratory movements. Are we good? Perfect. Now we all know who controls the diaphragm. Now for the forced respiratory movements. For the forced respiratory movements, we'll have those muscles which are called accessory muscles for the rest, like they are not working in the normal situation. So now these muscles are spleniae. How they are acting? They are elevating my first rib. So they are providing me more. I need to breathe more. So my spleniae come in play. We have anterior, middle, and posterior. And they are helping in fixing my rib. Then I'm looking at the sternocleidomastoid muscle. And then I have the pectoralis major and minor. And then I have the muscles of my anterior abdominal wall. All of them are acting. They are the muscles. They are helpful when I need more respiratory movement. So they are called accessory muscles of respiratory movements. So these are what? The normal muscles for quiet breathing are external intercostal, internal intercostal, innermost intercostal. It's different variants. And then the diaphragm. They are for quiet respiratory movements. For forced respiratory movements, we need accessory muscles. And these are my spleniae, my sternocleidomastoid, my pec major minor, and my muscles of the anterior abdominal wall. I'm sure you all be remembering them: external oblique, internal oblique, transversus abdominis, plus minus rectus abdominis. So they are helpful there. Are we good so far? So these are the muscles which are needed during the quiet respiratory movements, and the group of muscles which are needed during the forced respiratory movements. I hope we are clear with this all. So now let's look at it. On this slide, what I've tried to show you, muscles of expiration. So quiet breathing, this is a quiet breathing occurring, active breathing. So we are moving them. I have explained to you action of these muscles. So they are helpful for my expiration during quiet, and active when I'm using the extra muscles. And these are the muscles of inspiration. The principal muscle we talk about, external, internal, and then the diaphragm for inspiration, and accessory when we see look at them, the sternocleidomastoid and the splenoid, they come in play. So look at it. This is the pattern of my exhaling, quiet, and this is the exhaling, inhalation and exhalation. So these are important concept. This concept is really important, and you can understand how these muscles can play their role when we are exhaling, when we are throwing gases out, and when we are sucking gases in. So these are the different group of muscles. They come in play and they do their part, and if they fail to achieve that, we are having difficulty in breathing. And remember what happens when the air enter in my pleural space. We call this condition as pneumothorax. Now, lung will not be allowed to expand it to its full. When lung is not expanding to its full, it means there will not be enough gases exchange. As a result, we are getting less oxygenated blood for our body supply, and that will be resulting in disasters. So that's why we need to intervene in those situations. We have talked about and will be talking about in detail in our upcoming sessions. So now this is just a clinical thing, a clinical test of our knowledge of application. We talk about these things here. So this is the normal side of a chest x-ray. Guys, if you are having trouble in identifying why this is right and why this is left, I think there are two nice videos which has been uploaded in the structure of the week session. Kindly go there and be connected to that. And there is one more reminder. You have to fill in a survey form for your peer tutors, those who are helpful for your lab session. So please fill up that. I have seen only 57 girls have done that, boys haven't done it yet. So please, boys and girls, these forms are available, so do that. Anyways, so this is my mediastinum, this is the normal side, and this I'm saying abnormal side. We have talked about this x-ray before also. So now this is a collapsed lung. Look at it. This lung has been collapsed. It has shrunken. Here, this is a full expanded lung, and this is a collapsed lung. So all look at the color difference. So this is the dark black thing, and that is the air which has been filled in this space, and that is my air. This is a case of pneumothorax. Excellent. And these are those angles which I was talking early part of my presentation, costodiaphragmatic recesses. So now the hemothorax, this situation, you can see the fluid. Look at it, the angle is gone. Here the angle is there. So now this is the normal side, and this is the blood in the pleural space. Guys, these practices are important, and you are expected to be good in differentiating hemothorax from pneumothorax, at least on the given x-rays. This is one of your objectives. Thank you very much. Now guys, I'm open to your questions. If you have any, please feel free to ask. Let me go to your chat. Guys, do you have any question? So people are guys, are we fine? Okay, I can see that people are fine, but don't forget to fill in that survey, which is important for your peer tutors. Doctor, are the pericardiphrenic vessels are the same as intercostal? You remember when we were talking about intercostal vessels, we talk about the internal thoracic artery when it was going to the space number 6, then it was dividing into superior epigastric, and then we talk about musculophrenic, and then from the musculophrenic we get this we'll be talking about this pericardiphrenic. Don't worry for that. So please don't forget to fill in those survey forms which are important for your peer tutors, and peer tutors just request your friends, they can fill it for you. You need to have those. So guys, thank you very much. Stay blessed, stay safe, and take all precautions. We have to be careful. Bye bye.